Hello, everyone, and welcome to this very interesting lecture. We are going to talk about magnesium, which is very natural, not only in our body or our food, but also very abundant in our soil. We are going to focus on answering, or at least trying to answer this question. Is magnesium a heart-saving mineral? Again, this is Professor Amr El-Husseini, and I'm a professor of nephrology, and I'm the vice president of the World Kidney Academy and the president of the World Institute of Critical Care and Emergency Medicine. I don't have anything to disclose today. I don't get any money from any of the pharmaceutical companies. And of course, when it comes to magnesium, it's just, very available everywhere over the shelf or in the food. So you don't need to get prescription. And I don't own any stocks in the stock market for magnesium or any other pharmaceutical interventions. So we are going to focus on magnesium homeostasis to understand how our body handles magnesium. Then we'll talk about the importance of magnesium in all of our function of our organs at the macro and micro levels. Then the vast majority of this lecture will be focusing on impact of magnesium in CKD patients regarding the cardiovascular system, cardiovascular calcification, and our CKD patient survival. What I am not going to talk about today is the impact of magnesium on CKD progression, but I can tell you that there's good evidence that magnesium can also help to slow down the CKD progression, but this is out of our scope of our today's lecture. And also, bone loss is a big topic that I'm not going to touch today because there is no time. Okay, let's talk about how we handle the magnesium. So our daily magnesium intake is about 360 milligram. The vast majority of this is excreted in the stool, and only we absorb about 100 milligram of this in our blood. Vast majority will be excreted in the urine, and the very small part will be stored mainly in the muscle and in the bone, and it has very pivotal function and importance when it comes to bone and also to the musculoskeletal system. The problem when we measure serum magnesium, we have to understand that the total magnesium, the vast majority of this, 60%, stays in the bone, and the rest is mainly intracellular. So very small fraction, about 1% of this magnesium is in the extracellular fluid. So this is what we can measure. We don't measure the bone magnesium, we don't measure the intracellular magnesium, but we can measure only the 1% of the magnesium which is in the extracellular fluid. So it's important to understand that you can have magnesium deficiency, but you cannot detect because of you are only measuring 1% of the magnesium. So remember, 99% of our calcium stays in the bone, 85% of the phosphorus stays in the bone, and 60% of magnesium stays in the bone. And when it comes to magnesium, the least amount of magnesium stays in the extracellular space. Okay. Is magnesium important? Yes, magnesium is very, very important element in our body. Most or the vast majority of the enzymatic function depends on magnesium. More than 600 enzymes need magnesium to be biologically active. All kinases, ATPases, sodium, potassium, ATPase, adenyl cyclase. Also, the structural functions for the mitochondria, the Golgi apparatus, the nucleic acids, ribosomes, membrane stabilization with cell adhesion, transmembrane electrolyte flux in and out, the efflux and influx is the magnesium dependent. Even the calcium also, and the effect of calcium on neuromuscular and the cardiovascular system depends on the magnesium. So the reason that if you have magnesium deficiency, you would have pseudo or functional hypoparathyroidism, and this will lead to hypocalcemia. And of course, the vast majority of us know that if you are trying to correct the potassium and the potassium is not going up, the serum potassium, you need to think about magnesium. This might be the reason of this resistant hypokalemia is hypomagnesemia. So it's very pivotal, not only for the magnesium and its impact or effect on the cells by itself, but also it directly and indirectly affect the calcium homeostasis and the potassium homeostasis and the parathyroid function. If you have hypomagnesemia, probably you will have non-specific manifestation for our CKD patients. They could have depression, hemiparesis, weakness, encephalopathy, and up to aphasia. They might have cramps, so similar to hypocalcemia, fasciculation, carbopedal spasm, and of course, we talked about hypocalcemia and hypokalemia. Of course, its impact on the cardiovascular conduction system is huge because it can cause both ventricular tachycardia, supraventricular tachycardia, protracted BR and QT interval, prolongation of QRS complex, and pointed T waves. Also, there is magnesium losing disorders. The vast majority of these disorders are in the GI tract, but also there is renal disorders that can cause magnesium losses. So if the urinary magnesium is more than 24 milligram per 24 hour, that's probably a renal magnesium losing disorder. If it is less, it's probably secondary to the GI loss, secondary to frequent suction or diarrhea or malabsorption. Also, we have to remember that severe hypomagnesemia can happen, especially in our patient post-transplantation. Why? Because they have osmotic diuresis, they have polyuria, and the fluid we give, they lack usually magnesium. And especially if they are getting calcineurin inhibitor, which the vast majority are, and if we are giving loop diuretic. So there is several reasons for the early post-transplant patients to have hypomagnesemia, sometimes severe hypomagnesemia that is can cause some arrhythmia and could be symptomatic. But also other disorder, ketoacidosis, hyperglycemia, of course, due to osmotic diuresis can cause that. There are several drugs, cisplatin, alcohol, metabolic acidosis also cause hypomagnesemia. One of the new EGF inhibitor is cetuximab, and cetuximab is mainly used in colon cancer, very effective in colon cancer, but can also induce severe hypomagnesemia. Also, it's good to remember that there is familial disorders that can induce not only hypomagnesemia, but is also associated with hypercalciuria and nephrocalcinosis, and it's usually due to autosomal recessive disorder in collodine 16 and 19 with loss of function mutation that can cause kidney failure. Okay, let's focus now on impact of magnesium and the prevalence of hypomagnesemia in our CKD patients. So for a long time ago, we always thought that our patients have problem with retaining magnesium. They have hypermagnesemia, but studies in the last 2 decades showed that hypomagnesemia is prevalent. At least 15% of our CKD patients, stage 4 and 5, high hypomagnesemia. It's also very important to note that absence of hypomagnesemia doesn't exclude magnesium deficiency. So there is 2 things here. Total body magnesium deficiency is different because hypomagnesemia, we are talking about only the 1% of magnesium in the extracellular fluid that we can measure. But sometimes it's hard to understand this equation because the vast majority are outside the circulation. So there might be intercellular depletion of magnesium, but the serum magnesium level stays in the normal range. And this is very valid, especially if the patient has severe CKD or dialysis patient, or if the patient has acidosis, metabolic acidosis, for example. So in this study, it showed that the prevalence of hypermagnesemia, on the other hand, defined by total serum magnesium level, is about 69%. But when they measure the ionized magnesium, which is the biologically active magnesium, the percentage was down to 13%. And if you can see here, post-dialysis is improved because probably acidosis and the metabolic abnormalities in dialysis patient can actually pseudo elevate the serum magnesium level because it causes shift from intercellular to extracellular magnesium. So it can give you a fake or a masked hypomagnesemia effect. So it masks the hypomagnesemia. You can measure the serum magnesium level and it would be normal, but it doesn't mean that it's really, normal, or the patient doesn't really have magnesium deficiency. As you can see here, there is growing interest in magnesium in CKD patients. Studies in CKD patients are growing. And especially in the last decade and the last 3 to 5 years, there is a lot and more publications coming in, try to see or examine the impact of magnesium on our body. Not only that, but also there is a lot of prospective randomized study, as I can, show you in a little bit. So it's not only association, but almost causation. So what's the role of magnesium in our CKD patients? We are going to talk now about cardiovascular system. As you know, that cardiovascular calcification in our dialysis patients is mainly medial calcification, but also it could be an intimal calcification, especially in obese patients with type 2 diabetes, hypertriglyceridemia, hypercholesterolemia, metabolic syndrome. So it's a combination of both. And magnesium, as I will show you, can ameliorate the impact of traditional and non-traditional risk factor on cardiovascular calcification. So it's not only calcification, but the impact of magnesium on cardiovascular system is huge. It affects the vascular smooth muscle cells. It affects the calcium homeostasis. It can induce vasodilatation, decrease the peripheral vascular resistance, increase nitric oxide, decrease the inflammatory mediators, decrease platelet adhesion and aggregation, and free radical. And also it has anti-ischemic effect and anti-arrhythmic effect. So many, good things that magnesium can cause. But let us focus on what we understand is the major risk factor for mortality in our dialysis patient is a cardiovascular calcification. Can magnesium ameliorate or mitigate or slow down this cardiovascular calcification? And yes, it can, because there is several studies, ex vivo and in vivo, experimental and clinical studies, observational and prospective studies that showed that magnesium can lower down the cardiovascular calcification progression. So to understand this process, which is a little bit complicated, so calcium and phosphorus, which are, as you know, are major risk factor of cardiovascular calcification in our patients, especially if they are on a positive calcium and positive phosphate balance, especially if there is demineralization of the bone because of hyperparathyroidism or because of dead bone because of the low or adynamic bone disease. So the calcium and phosphorus moves to the circulation, but it's soluble. So it's not very injurious, but it's very injurious when it transforms from the soluble form to crystalline form. So calcium and phosphate start to crystallize with a protein called phytoin A. And what happens is if our patient have excess phosphorus and excess calcium, these particles, which are circulating freely in our blood, start to cluster, start to combine together. Then the phytoin A, which is a protein, will carry this particle. And now we have what we call calciprotein particle 1. It's not injurious because it's still amorphous. It doesn't precipitate in the blood. But what happens if there is excess phosphate and if there is magnesium deficiency, This calciprotein particle 1 transforms to, maturates to calciprotein particle 2. And as you can see, this CBP2 is sharp crystal. It's a crystalline, it's amorphous, it's hydrophobic, it's not hydrophilic. It precipitates in the tissue, especially in the cardiovascular system, causing calcification. And also it induces a state of oxidative stress and inflammation. And also it's injurious not only to the blood vessel, to the vascular smooth muscle cells, but also to the kidney itself. So here is what we can see. Here is the primary CBP, the calciprotein particle 1. It's amorphous, it's not sharp, it doesn't injure the vascular smooth muscle cells. It circulates in the blood, it doesn't deposit in the tissue, but in absence of magnesium, these amorphous crystals change to a needle-shaped, sharp crystals and start to precipitate and start to induce an acute phase of inflammation and injury to the vascular smooth muscle cells and start to initiate the calcium phosphorus pyrophosphate crystallization. And this maturation from CBP1 to CBP2 happened because of positive calcium balance, hyperphosphatemia, low FIT-Win, and low magnesium. So several studies like this study, which is the ex vivo study, in absence of magnesium, if we have high calcium phosphorus in the media, start to form this hydroxyapatite crystal, calcium pyrophosphate crystals. Here are big calcifications like cannonballs. But when you add more magnesium to the medium, you will see that by adding more and more magnesium, there is no crystallization. Not only this, but also studied in rats. So in 5-6 nephrectomized rats, you can see they will have, if they are on a low magnesium diet, they will have severe cardiovascular calcification because of their advanced CKD. But if you feed them on a high magnesium diet, this will ameliorate the cardiovascular calcification. Not only this, if you give the magnesium intraperitoneal, also this will decrease the chance of cardiovascular calcification. Same thing here, this is a control group, but if you give a lot of phosphorus in the media, there will be calcification and precipitation of the calcium pyrophosphate crystals, but this happens usually in absence of magnesium. If you add more and more magnesium, this will try to reduce the risk of cardiovascular calcification. Here, same thing, smooth muscle cells here of the blood vessel looks okay with the primary CBP, but secondary CBP, there is, crystallization and there is injury of the vascular smooth muscle cells that induce severe cardiovascular calcification. There is very good association between CBP2 and cardiovascular calcification. So magnesium is a potent inhibitor of this transformation and maturation of calciprotein particle 1 to calciprotein particle 2. So this is just the theoretical background. Let's talk about studies. Let's try, to move from this bench to bedside. So studies showed that, okay, let's test this hypothesis. Let us give magnesium oxide, which is very available, to our CKD patients, in this study prior to dialysis. And they followed this patient for 2 years, and let us see what happened. So magnesium oxide was, the group who received magnesium oxide has less cardiovascular calcification, especially the coronary artery calcification, the CACs. So both groups gained some over the 2-year period, but the control group had significantly higher cardiovascular calcification, especially those with the rapid progressor who gained more than 15% of the calcification, especially those with a baseline CAC of more than 400. So if you have a patient with higher baseline CAC, coronary artery calcification, and you put him on magnesium oxide, there is a good chance that you can slow down the progression of this calcification in the coronaries. This study did not show impact of magnesium on progression of aortic calcification, but only on coronary. Okay. this happened in CKD patient prior to dialysis. So, but might be the story might be different in hemodialysis patients. So another Japanese group tried to prove this concept in dialysis patients. To give a good amount of dialysis patient magnesium oxide, and they control it in a prospective randomized fashion. As you can see, patient who received the magnesium oxide had a higher serum magnesium level over 6-month period. And the patient who received the magnesium and have higher serum magnesium level, they have a slower rate of calcification as measured by the T50, which is the time taken to calcify the blood sample. So magnesium oxide patient, after 6 months, you see this prolonged period of T50. It took longer period for calcification. The control group actually in 6 months, this period was shorter because the calcification progressed over 6 months, but it slowed down in this group of patients who received magnesium oxide. And this was unrelated to any other biomarker like serum phosphorus, calcium, or BTH. So it seems this magnesium impact on cardiovascular calcification is unrelated, independent on other biomarker. And also they examined the effect of the change in the serum magnesium level to these patients on the change of the T50, the time to calcify. There is very good linear relationship. But if you increase the serum magnesium level, probably you're going to prolong this calcification process. Okay, so why to give a magnesium oxide to dialysis patient? We actually can customize the dialysate magnesium. We can just, have a luxury here. We have magnesium and phosphorus and the calcium and all electrolytes in our dialysate. Why not just to customize and increase the magnesium level in our dialysate? So here's the random these 136 patients either to low magnesium in the dialysate, 1 milliequivalent per liter or 2 milliequivalent per liter, and they followed them up for short period, just for 42 days. Of course, patients who were on a higher dialysate magnesium, they had higher serum magnesium, but also they had prolongation of their T50, so they have a longer time to calcify. Not only that, but also in follow-up studies, they showed that the total CPP was down in the higher magnesium dialysate group. Also, CPP1 was down in the vast majority. CPP2 it was down, and more importantly, the CPP2 to CPP1, this ratio was significantly down in the vast majority of these patients. They also examined the other tumor necrosis factor and biomarker of inflammation, interleukin-6, bone-specific alkaline phosphatase improved, and TRAB5B, which is a bone resorption marker, decreased. So this means that there would be also an impact not only on cardiovascular system, but on bone. Okay. So studies, prospective randomized clinical studies showed that improving serum magnesium is associated with improvement of cardiovascular calcification, or at least you can slow down the cardiovascular calcification in this patient by giving them magnesium or increasing their dialysate magnesium. Let's talk about mortality. Can this impact mortality? As you can see here, the vast majority of our patients die because of cardiovascular calcification, which is related to the hyperphosphatemia. So there is very good linear relationship between serum phosphorus level and the odds of mortality in this study. But this happened in patients with low magnesium level. In patients with normal serum magnesium level, this impact is trying to flatten. See, this is more vertical. Now it's flattening. And now patients with a magnesium level of 3.1 milligram or so, higher or on the higher side of serum magnesium level, and this happened on very big number of patient national database from Japan. It flattened. So the impact of high phosphorus on patient mortality now is vanishing. So it looks like this happens. The bad impact of hyperphosphatemia on our patient outcome is mainly related to the hypomagnesemia. It depends on the magnesium. So if you improve the serum magnesium level, you would flatten this curve. Another also database, a national database from Japan, shows that the best survival, the lowest mortality happen if the patient have serum magnesium level of about 2.5 to 3 milligram. Of course, hypermagnesemia might also be bad, but if you can see here, hypomagnesemia was severely impacted the odds ratio of survival. So it's very steep. The relationship is very vertical. So again, hypomagnesemia can increase the risk of myocardial infarction, heart failure, strokes, and even cerebral hemorrhage. So magnesium is available everywhere, and it would be an interesting natural supplement to help our CKD patients, especially diabetic patients, because magnesium deficiency happen in diabetic patients, as we talked about at the beginning. Hyperglycemia, osmotic diuresis can cause magnesium loss. So magnesium loss can impair insulin sensitivity, can cause insulin resistance, chronic inflammation. It's also associated with obesity and metabolic syndrome. And there is several targets to decrease the calcification. There is natural calcification inhibitors in our body, and one of them is the magnesium. So that's for interest, and that actually doesn't only decrease calcification, but decrease the oxidative stress, chronic inflammation, and can improve cholesterol and reduce the effect of FGF23 on the blood vessel. Several other studies, and don't have time to show you more and more studies, show that increasing serum magnesium, adding more magnesium would be associated with prolongation of T50. And this is a very particular study because this was done for stage 5 patient prior to dialysis, which is very rare actually, because these patient doesn't stay long on CKD stage 5 prior to dialysis. So to have this kind of studies is very, very rare. And it shows that a patient with higher magnesium level, they have less aortic calcification, and patients who were given magnesium oxide also was associated with less cardiovascular calcification. So this is a review study published also this year, trying to examine the impact of low serum and dialysate magnesium on clinical outcome. And the conclusion was low serum magnesium level have been associated with a range of unfavorable outcomes, such as vascular calcifications, fractures, and hospitalization. And some large cohort study found an association with all-cause and cardiovascular mortality. So this was their conclusion. Another study also that examines the impact of serum magnesium on cardiovascular outcome and mortality. This was a prospective randomized study from CREC. If you are familiar with CREC, it's a chronic kidney disease cohort. They publish a lot. And actually, it's an observational study, but this one was a prospective cohort study on very big number of patients, close to 4,000 patients. Patients with serum magnesium level less than 1.9 or more than 2.1 was associated with increased risk of all-cause mortality. So it's the best level, it seems, is to keep our patient serum magnesium between around 1.9 to 2.1. This is associated with better outcome. As you can see here, these are 3 tertiles. The best tertile was for patient who had serum magnesium level around 2. This was associated with less mortality and also with less congestive heart failure, MI, strokes, and peripheral artery disease. Again, this is very new study that shows that our patient with upper normal serum magnesium level is associated with decreased fetal heart failure, coronary artery disease, stroke, and non-dialysis patient with CKD stage 4 and 5. As you can see here, they have very good number of patients, more than 1,200, stage 4 and 5, and they followed this patient for 5 years. Again, patient with higher serum magnesium level, higher normal serum magnesium level was associated with better outcome, less congestive heart failure, less coronary artery disease, less stroke, and better survival. This was again published this year. Just to make things complicated, one study here, which was also very well designed, randomized, double-blinded, placebo-controlled parallel group clinical trial for stage 3B and stage 4 CKD patients. They random this patient to receive magnesium hydroxide or placebo 1:1. They followed them up for a year, and they examined the impact of magnesium hydroxide on coronary artery calcification. But in this study, they didn't find impact, or at least positive impact, or good effect of magnesium on cardiovascular calcification. So magnesium did not slow down the progression of cardiovascular calcification, even this patient has higher serum magnesium level. So this is just one study didn't show this effect. We are all awaiting the results of this big randomized prospective controlled study called Roadmap that is going on now, not only trying to improve the magnesium by giving magnesium citrate, but also trying to decrease the phosphate by using a phosphate-lowering therapy. So combination, not only targeting the magnesium, but targeting the phosphate at the same time, but the results is not up yet. Again, I'm not going to talk about magnesium and CKD progression, but there is good evidence that magnesium administration or treating total magnesium deficiency can improve the CKD progression or slow down the progression. Also, I'm not going to talk about the effect on bone, but it seems that there is double faces. It's like a genus face of magnesium. So it actually inhibits cardiovascular calcification. We all, now I think convinced by that. It prevents cardiovascular events, and it's associated with better survival. However, you need to avoid any bone demineralization. You need to exclude osteomalacia before you give this, because there might be a negative impact of extra magnesium on bone. We are not going to talk about this today. But anyway, magnesium is a new player in CKD MPD. So it's not now only the calcium, the phosphorus, the VTH, the FGF23, and too little is bad, maybe as too much. So we have to moderate. And actually, you can see here all the impact of magnesium, not only on the cardiovascular calcification, but on endothelial function, and also on the PTH suppression and on the bone. The major effect of magnesium, it inhibits osteogenic transformation of vascular smooth muscle cells, so it prevented from transforming to a bone-like cells. Again, I think we are all convinced that magnesium deficiency is not uncommon in our CKD patient. Don't be afraid to correct the magnesium in our dialysis patient. Magnesium is a potent cardiovascular inhibitor. It's natural. We can either give it, especially in patients with constipation, because it has laxative effect, but don't give too much because it can also induce more losses of magnesium in the GI tract if the patient develop diarrhea, which is very well-known side effects of magnesium. Hypomagnesemia is associated with higher mortality, and hopefully by correcting the magnesium deficiency, we can improve our patient survival. What I'm not focusing on today is impact of magnesium on CKD progression. But again, I promise you, if we have another chance, I can give you more details and can prove this concept that improving magnesium deficiency can slow down the CKD progression. More studies are needed to determine the impact of magnesium on bone, which is magnesium is basically a bone element. 60% of magnesium stays in the bone, but this complex relationship need different talk. Improving magnesium deficiency is a potential target to improve CKD outcome. It's very cheap, it's highly available, We don't have any conflict with it. Toxicity is very minimal. So I really encourage everyone, try to check periodically the serum magnesium level. If you have access to do ionized magnesium level, this would be better. And of course, all of this knowledge has no value unless we put it in practice to try to improve our standard of care, our clinical practice, and our patients' outcome, because the great aim of education is not the knowledge, but the action. Thank you so much.